tube, and it could be in 2.8 days that that feeding tube is placed and they're discharged home on it, or it could be a little bit longer journey. But there's not a lot of time to make decisions about the right fit for the long term, because not all feeding tubes that are placed stay for the long term, right? And the clinicians and physicians that are placing these tubes in the very beginning are not making decisions for 3 years out. They're making decisions for right now. So my goal here is to empower you to take agency in your own feeding tube selection, and like I said, educate clinicians on how to help their patients do that as well. My name is Cynthia Reddick. I'm a registered dietitian and certified nutrition support clinician. I've been working in home care since 1999, passionately supporting patients' experience on tube feeding. At the end of the day, I hope to baptize every clinician in this room to help advocate for patients to have a better experience with their feeding tubes in the long term. My financial disclosures are listed here, my relevant financial disclosures. And what we're going to learn today is I'm going to introduce you to a variety of different feeding tube options that are out there, but I'm going to introduce you a little bit more intimately to their design, how they're placed, and a little bit about the anatomy of that placement, and then ultimately we'll review best practices. That it's going to tee everything up for helping to prevent complications with those feeding tubes so that you have a better experience with that feeding tube. So considerations in feeding tube selection are listed here. And so we have to think about what is the functional purpose of that feeding tube? What function is it going to serve? Not all feeding tubes are actually used for feeding. So that's something to keep in mind. What are the socioeconomic impacts? What kind of insurance coverage patients have? And at the end of the day, ethical considerations also play a role in that acute care experience in making feeding tube choices. So I apologize for the distortion on these. It's not showing up quite right, so we'll try to go through this a little bit. But what I wanted to introduce you to here is this idea of French size in a feeding tube. So what you can see here is an incremental increase in the French size and what that variation can look like, but also introduce you to what does this French size mean? What is a French, right? So it's actually a measurement. It's a measurement of the outer diameter of a feeding tube, but as clinicians and patients, we're always very concerned with the inner diameter and what can go through that feeding tube. But I'm going to introduce you to the insides of these tubes in a little bit, give you a little bit more perspective on French size, but the French size is an outer diameter measurement in millimeters times 3. That's the actual calculation. But that inner diameter is not 100% dependent on the actual French size. So sometimes it's impacted by the type of material that tube is made of, and whether it has a balloon inflation device on the inside as well. And so I'll walk you through that a little bit. But first, let's talk about gastrostomy tube placement. And I love this image so much because it shows all the important anatomy as it relates to proper tube placement. And I hope that you sort of keep this image in your mind. It's going to show up a couple times throughout this presentation, but this is important to understand when, and this is a gastric tube that you're looking at here. There's the most common placement techniques are listed here. And so an endoscopically placed tube is placed by a gastroenterologist in the GI lab. There are radiologists that place feeding tubes, and they place those tubes in interventional radiology. And then sometimes tubes are placed in a surgical suite when a patient is having like an open surgery. So there's several different types of departments in the hospital, and they all have different tubes, and there's different options for those different doctors that are placing those feeding tubes. But at the end of the day, the way that tube is placed still results in an internal retention device, which is what you're looking at here. This is an example of a balloon internal retention device, and that's filled with water. And then you have this external bolster here. And this is, for lack of a better term, it's actually a term that I learned from consumers. I'm going to call this a dangler style tube, so just remember that term, dangler style. It's also a standard profile feeding tube is what you're looking at here. But what you'll see is that when that tube is initially placed, this internal retention device is placed up against the internal lining of the stomach, and then that stomach is hoisted up against the abdominal wall here, which is not the normal position of your stomach. Normally it's, in over here, but that internal bolster helps hoist that internal lining of the stomach up against the abdominal wall. Then the external bolster here provides a little tension, and so then you get to create a stoma tract, and that's what's happening here. This is the stoma tract. And so it's really important in those first 6 weeks, 8 weeks, 12 weeks. Doctors do not like to replace feeding tubes because this part is maturing. The stoma tract is maturing. And adhesions are created here, and that's a good thing. So that helps keep the interperitoneal space here from getting any formula or medication or water in here. It's bad when we have those types of liquids in the interperitoneal space. So this concept is really important for you to understand, like, what does it look like on the inside? A lot of patients don't know what it looks like on the inside. They just see, the dangler on the outside. But this is what's happening, and it provides access. This is your prosthetic. So that action of adhering the internal lining of the stomach to the abdominal wall, of fixing it, is called gastropexy. So that gastropexy technique is what helps create a healthy stoma tract and one that makes it safe to feed. So there's several different techniques in which to gastropexy, and one is with T-fasteners. And so some of you may have had a feeding tube, or clinicians in the room may have seen patients with these little button-looking things that are either underneath the bolster or out around the outside of the bolster when it's initially placed. And there's this tiny little metal T-bar that's underneath, and that little metal T-bar has a suture that goes up through all those layers of skin and abdominal viscera to the outside, and it helps to compress that stoma tract to help create that adhesion so that there's a healthy stoma tract. Another way is sometimes physicians will suture and just create a suture that goes all the way through this thickness. And sometimes they'll suture it through a bolster, or if there's no external bolster, they'll just suture it to the skin. And what that's doing is helping to create that safe stoma tract environment while it's healing and creating those adhesions. And then this is just a simple bumper bolster combination where you just have the internal and the external bolster, and they are advising you to make sure that that bolster stays put for a good period of time. So now we're going to talk about common feeding tube types that you see in long term. So we're going to talk about gastric tubes first. And so this is the standard profile gastrostomy tube, what I referred to as a dangler. So that's my affectionate term for it, because that's pretty much what it does, is it dangles. And this feeding tube has the soft, pliable, there's not a balloon here, so you can see the soft, pliable internal retention device. At the end is the feeding port. You've got a feeding port here and a little med port here. Here's your little clamp, and then this is the external bolster. And this is what it looks like when it's all disassembled. So when this feeding tube is first placed, you've got this piece that's placed endoscopically. So this is placed by a GI physician in endoscopy, and this feeding tube is placed from the inside out. And it's usually, 3-4 feet long, and then it gets cut down. And I was talking to a consumer yesterday who was explaining that when he first had his feeding tube placed, he had this 2-foot-long section of feeding tube hanging off when he first had his feeding tube placed. That wasn't super convenient for his lifestyle, but it's something that we see commonly. But understanding that these PEG tubes can be cut down and then put back together to size right for the patient. But the physician who's placing the tube doesn't generally know what that patient's lifestyle is going to be like at home when they go home. So they are just doing sort of a standard procedure that is like a one-size-fits-all, but it doesn't always fit all. So this is an example of, and gives you a look inside what that standard profile PEG tube looks like. And you can see the internal lumen here is a 20 French. Here's a 24 French. Both of these are out of the same material, so they have the same sort of thickness here, but you can see the difference in size, and so it's just something that I wanted to share with you so you could get a look at what that looks like. And then this is a different type of dangler. So this is a balloon gastrostomy tube. So instead of having that soft internal retention, that little soft bolster, you have the balloon that I referenced. And this is filled with water, not air. So make sure you understand that. This should always be filled with water if you have a balloon gastrostomy. This is connected. Nothing comes apart here. The tube comes all assembled in this way, and none of this part doesn't pop off. This part can't slide off. It's placed from the outside in, and it's often placed in interventional radiology. And these tubes can be used as replacement tubes after a PEG tube has been placed. Like the prior tube I showed you, this could be used as a replacement tube because it can be replaced in clinic by a skilled clinician. So now I want to introduce you to the inner workings of those balloon gastrostomy tubes because I think this is really interesting. So here's another example of a balloon gastrostomy tube. This is a feeding port. This is an extra feeding or medication port, and you can see that these two ports feed down into the same lumen here, and this is what feeds down into the stomach. And then this port here, this is your balloon port. So when you're looking at a feeding tube from the outside, if you have this extra balloon port, then you know you have a balloon gastrostomy tube. And this tiny little lumen right here, you can see it a little clearer here, is what feeds, not air, it feeds water down into that balloon, the internal retention device. Oops, wrong way. And so on the inside, just comparing a balloon gastrostomy tube, this is your balloon gastrostomy tube. This is that PEG style dangler that I showed you. They're both 24 French, so they have the same outer diameter, but what you can see here is that balloon gastrostomy tube has a little curvature here, and a little bit of that internal lumen is taken up by that balloon port and lumen. So this view, I want to show you what the differences are of internal retention devices. So here's your balloon gastrostomy tube. This is what it looks like on the inside. This tube happens to be a balloon that holds 20 milliliters of water, so it's a little bit larger than many, but it does show you what that balloon internal retention device looks like compared to the soft PEG-style feeding tube. And the openings here, too, this is what is delivering the nutrition. So your formula comes out through these little openings. So a gastrojejunostomy tube, some people in here may have a need for gastric access as well as jejunal access. And this feeding tube provides both access through one single tube, or one single stoma tract. So this feeding tube, these are both GJ tubes, but they're different. This one's a balloon style. This one has that soft internal retention device. And so you can see that this G tube port feeds down here and would deliver or suction out of this section. And anatomically, if you think about this sitting on the inside lining of the stomach, it helps you understand how the feeding tube, when you're just looking at a tube, how it actually works. So this would be sitting on the inside lining of the stomach, and if you needed to drain or suction out of the stomach, it would come out of this port here, the G-tube port. But then there's this J-tube section that feeds through the G and would deliver nutrition down into the jejunum. And so what you feed through this J-tube port comes out down here. And this is basically the same format, it's just a little bit different style. You can't see the opening like you can in here. So you've got your, I think that's the G. You've got a G and a J-tube port, and then this extra balloon port. So again, your balloon port is going to inflate this section. What goes through gastric is going to come out little openings right here, or suction out of little openings right here, which is giving you access to the stomach. And then the jejunal feeding port delivers nutrition out the very end. There's little holes in the tube right here. So that's how you would bypass the stomach and feed into the jejunum with this feeding tube. And some people have low profile gastrostomy tubes. Sometimes we call these buttons. So this is an example of a button that is a non-balloon style. So it's got a soft internal retention device there. When it's time to feed, you just plug in your extension sets and you can feed. The extension sets plug right in here. But when you're not using that feeding tube, this low profile device gives you a really nice option for discretion. And so you're going to get a chance during the roundtable sessions later today, you're going to get a chance to get a closer look at the difference between dangler style or standard profile tubes and low profile buttons. So I invite you to check out Kara's table where she's going to be showing those differences. But again, this is your non-balloon button style. And then this is your balloon style button, which is probably the more commonly placed feeding tube that we see as buttons. So you've got your balloon port here, and that inflates this balloon internal retention device there. And when it's time to feed, you just pop that open and you put in your extension sets, and you can get a hands-on closer look at that during the roundtable sessions today. And I love this shot because it shows some variation in options. There are so many options out there for low profile devices. And just because you had one kind placed for, your initial or secondary placement, you as the owner of your prosthetic have some agency, and you can make some decisions or make some requests about maybe a different option that suits you better. The important thing to know about low profile devices is that unlike the dangler style tubes, which are adjustable with that external bolster, you can adjust the size of that. It's kind of a one size fits all that way. The low profile devices have to be sized and fitted properly. And the most common problem I see as it relates to complications with low profile devices is that it's just not a properly fitting button. And so that's a really important part of it. When you have balloon style buttons, you can have a little bit of adjustment size-wise just by changing the inflation. Like if you were to inflate this balloon a little bit more, it would fit a little snugger. But you can't do that with these non-balloon styles. So keep that in mind when you're making decisions about low-profile devices. So this is a little snippet. Now that you've learned about the different components, sort of the anatomy, not only of the placement of the tube, but now you know the anatomy of these feeding tubes, you can figure out what kind of feeding tube you have just by looking at the port on your feeding tube. So for the clinicians in the room who are managing tube-fed patients and making assessments, I want to see you looking at your patient's feeding tube and identifying, you can tell just by looking at the outside what kind of a tube it is. So if you see this, because we don't have the privilege of being able to see inside, right? So we're not exactly sure. We don't always have access to that tube placement procedure report right away, but you can get a sense of it. So this is your danglers, right? So if you've got that balloon port here, then you know you have a balloon internal retention device. You know you have something to manage here because that balloon inflation matters as it relates to the long-term health of that feeding tube and also any complications that may occur. So again, this PEG tube does not have a balloon port. So you know it's got something else on the inside keeping it in place. And then the same is true with your low profile devices. There's your balloon port. This one has no balloon port. And all these references are from a paper that I published when I got inspired about this idea of patients taking agency and deciding what sort of device fits their lifestyle, but also it was written for the clinicians that care for these patients to empower them to advocate for their patients. The reference to that paper is listed there, but I wrangled together some of my fellow feeding tube nerds in the home care community. One of them's in this room, Kara. She'll be managing the table that's going to basically be showing the difference between balloon style, non-balloon style, low profile device, and dangler style tubes. But that's where this reference is from, so you can have access to it there. So this is a case example of somebody who has two feeding tubes, two stoma tracts, two access points. So I showed you a picture of that GJ tube that has access to both gastric and jejunal with one stoma, but sometimes patients have two stomas. You've probably encountered those. You may be sitting in this room right now where you have, this is a G tube, gastric access. This is a J tube with jejunal access. And there's two different kinds of tubes here. So in this G port, there's a dangler style gastric tube. The purpose for this G tube is drainage and venting. And she prefers a dangler style tube for that. So she has chosen a dangler style balloon gastrostomy tube in order to vent. She has better success with that dangler and draining. So that's why she has that there. She test drove a button in there and it didn't work for her. So that is her access here. And then here she's got for feeding the J tube, a low profile device. This is in fact a gastric feeding tube, but it's placed jejunally. And we do see that from time to time. So it's important to understand that it's a G tube, but it's being used jejunally. And she has pump feeds in her jejunum, so she has a right angle extension set plugged in there. But she has designed her access devices to meet her needs and the functions that those stomas are serving for her. So now I've laid the groundwork for how these tubes work, how they're designed, how they should be properly fitted, and we'll kind of go back and reference some of that as we go through some tube site complications. These are the most common things I see in home care. It's what I see plaguing patients over the years. So I hope to impart to you some strategies to help your patients and help yourself as it relates to preventing some of them. So when we're assessing tolerance in tube feeding, as dietitians, we do this all the time. We're checking for nausea, vomiting, diarrhea, constipation, right? Digestive tolerance. But I'm a little more passionate about this tube-related tolerance because I know that if my patients are having a better experience with their feeding tubes, they have a better relationship with their feeding tube, they're more likely to be compliant with that feeding. So that's what we're going to dive into now. Wow, this looks really awesome. Sorry about this. Your brains can fill in the gaps here. You can replace the letters where they're supposed to be. But we're going to talk about leakage. We're going to talk about obstruction or clogged tubes. We're going to talk about tube displacement or when tubes fall out. And we're going to talk about stoma complications. All right, so the leaky tube. This is one of the most common complaints I hear. So you can see one with a low profile device. You can see a little leak coming out here with a dangler style. It's really important if you have a leaky tube to protect your skin with barrier cream. The things that are leaking out here are not hospitable to skin. It creates redness, irritation, burning, yeast infections. It causes a lot of problems. So first thing you want to do is protect your skin with barrier cream and then begin the process of identifying what is causing this leak, right? So it's often a bolster that's not placed properly. If that bolster is set back too far, then you don't have that gastropexy thing happening. You don't have that balloon or internal retention device resting up against the inside lining of the stomach. And so that balloon, if it's pushed away from the stomach lining, can allow fluids to leak out. So make sure that the external bolster and internal bolster are set properly. And then if you have a button, make sure that that button is sized right. That's really important. And then balloon inflation matters. So here's an example of a 4 ml fill versus a 5 ml fill, and you can see the difference in shape. So if this is sitting up resting against the inside lining of the stomach, you're more likely to have like what I call a pseudo seal, like it's less likely to have leakage come out. But here you could see how easily it would be for stomach contents to leak out outside of that balloon. The other thing I find is that brand new tubes, often those balloons are kind of sticky and rigid, and when you first inflate it, it can be lopsided. So I really recommend people pre-inflate their balloons and massage them and make sure that they're symmetrical because you could see how easily this could lead to a leak as well. And then lastly, you can't see this down here, but this happens, and there's probably some of you in this room right now who are power feeders. and like to feed really fast and get it over with. And so I've encountered some patients who were just filling too much into their reservoir. They were filling too much into their stomach, and it was literally leaking for no other reason except that their stomach was too filled with fluid, whether it was formula and water, etc. Okay, so clogged tubes. My PSA about clogged tubes is to really make sure that you're flushing appropriately and as a good habit before and after anything that goes through that tube. So I call that a water sandwich. So you want to flush the tube before feedings, after feedings, before and after medication, before and after any food that goes through, and just to help keep that tube clear, what we call patent, and make sure those medications are going through one at a time. And if you have a J tube or a smaller bore tube, flush more frequently. It doesn't mean you have to get up in the middle of the night and do it all through the night like they did in the hospital, but throughout the day, every 3 hours, just a little push of water through there and make sure that things are flowing nicely. And make sure that if you're using blends, you're using a very high quality blender and that you're blending for extra time to make sure things are going through smoothly. But if you do encounter a clogged tube, you can try a little manual massage. If you can see the clog out here, usually they're invisible to us and they're on the inside, but if you do see a clog in there, you can massage it. Use a 60 ml syringe and use this push-pull technique with some warm water. Or if you have a med port, an ancillary port, you can try a smaller syringe. No smaller than 6 ml, but a 6 ml syringe can give you a little extra force and help dislodge maybe what's on the inside. Tube displacement is basically if your tube falls out, maybe that balloon ruptured or got tugged on, or you got up out of the car and forgot that your backpack was sitting on the seat and you started to leave the car, but your backpack was still in the car. Sometimes that might cause a little tug on your tube, but you really want to make sure that you secure that tube and extension sets, and choose the right tube for your lifestyle. Again, I was talking to a consumer yesterday. I'm scanning the room for him right now, but he's a busy guy. He's a woodworker and he's active and he hikes and does all these things. So having a dangler tube is not a really awesome fit for somebody with that active lifestyle, right? If it's just the caregiver that's doing the tube feeding at home and the patient is bedbound, well, having a long dangler makes a lot of sense, but maybe not for somebody who's a little more active. So if this feeding tube comes out because of that, most of the time you've got to get into the ER, get into clinic and have that replaced as soon as possible. That stoma can close within 2 hours. So if you're skilled at replacing your own tubes, which a lot of you are, my recommendation is to wash that tube off and put it back in and then tape it down and then get in. If you have a backup tube that you can replace, use that backup tube. But if you don't have a backup tube, get in and get a new tube replaced. But the concern and the scare for clinicians is making sure that that tube is all the way through the stoma tract. The fear is that it's only partially in and then you start feeding into here. That's why everybody's a little tentative and will always tell you to go to the ER because they want to make sure things go all the way in. And if you try to put a feeding tube through a stoma and it's not the right size or it starts to get irritated, this gets all swollen and then sometimes you can't get the feeding tube through the stoma and it looks and feels like it's closing, but it's getting inflamed if you're causing that trauma. So just take care of that quickly, but do your best to prevent that dislodgement. Okay, so now we'll talk about the more common complications that I see, and I can dig deeper into this in my roundtable, so if you want to talk further about this, I'll go there. Let me check my time. I'm doing okay. But let's talk about let's talk about hypergranulation first. That's probably the most common thing I see, and hypergranulation is also referred to as proud flesh. It's this sort of growth that you might see around the stoma site. And it's like, I'll show you different examples at my table later if you come see me, but they're like snowflakes. They're all a little bit different. But it's this spongy, highly vascular, very uncomfortable mass of tissue that grows. Usually there's a cause, like if a button is too big, in this case this button has a little bit too much movement here, sort of in and out, that in and out motion and that's why the external bolster on the long dangler tubes, having that set properly is really important, because if this tube slides in and out microscopically throughout the day, that friction can cause that hypergranulation to grow. And it's not benign. I've had a lot of clinicians tell patients, it's normal, we're used to seeing that, and they don't do anything about it. But I have a problem with that, because that hypergranulation is an ooey gooey factory. It creates its own, let's use the word ecosystem, shall we? So it creates its own ecosystem of moisture, and sometimes people think it's a bacterial infection, but really it's just that tissue generating its own goo, and then it makes a bunch of moisture and can lead to things like yeast infections. So what do? You want to secure the tube, you want to make sure the bolster's set properly, make sure your button is the right size. I've seen too many tubes being ordered and replaced without an actual measurement. You can, in fact, measure a stoma tract and size a button properly, but it takes some advocacy sometimes. So if you do have hypergranulation, there's a lot of different approaches and techniques, but my preference is to use an over-the-counter hydrocortisone cream, very specifically on the hypergranulation only, and do that a couple times a day for a couple of weeks and see if that beats it down. And if not, then you can go towards a prescription grade. If it's resistant to that sort of approach, you can move on to silver nitrate, but that's not my favorite first effort, because it hurts and it burns and it creates this really unpleasant experience for a consumer. So if you can try with a conservative approach and beat it down that way and fix the underlying cause of that hypergranulation, then I feel like that's a better approach. Now, yeast infection is another very common thing. I often see it in combination with hypergranulation. But yeast infection is this erythemic, that's our fancy medical word for red irritated skin. It's inflamed, so this red erythemic skin here, there's little satellite lesions. Yeast infections hurt, they itch, they burn. It's very unpleasant for patients. So you need to protect that skin from, there's always leakage. There's always moisture or excessive sweating or something going on that leads to this. So you have to resolve that excessive moisture issue to prevent it from coming back. But you want to protect the skin with barrier cream. You want to get an antifungal topical going on here with a cream or a powder a couple times a day for a couple of weeks, and just watch that calm down. And sometimes you can treat that erythema with a hydrocortisone cream to sort of calm down that red irritation. But that hydrocortisone cream you really only want to use until that redness goes away. It's not something you want to put on healthy skin. And then bacterial infections are the least common thing I see. This is a really severe one. This is cellulitis, but this is from a patient who had a feeding tube. This is a jejunal tube. They had a red robin catheter placed as a jejunal tube. You can see the sutures holding it in place there. But this patient, this was so bad, this patient needed systemic antibiotics. And so that was the route we went with that patient. But we don't know what caused this. It could have been from placement. It could have been from lack of education on how to clean that tube site. We don't always know what causes bacterial infections, but we do know that they need to be addressed quickly. So this is a compulsory slide. It's in all of my presentations. It's actually an Oley ambassador who is usually here, but he showed up at our Newport Beach Oley picnic about, 6-7 years ago with a brand new tattoo. And so I snapped a picture of it because I love it for so many reasons. So first of all, this do not overfill, this is real, okay? So going back to our power feeder patient population who shall remain nameless in this room, but if you're a power feeder and tempted to overfill, you don't want to overfill your reservoir, so take it easy there. But I love this picture because it's a properly fitting button. Look at that. It fits so nicely. He has a really nice healthy stoma. It's not red or irritated. So it's really giving you a good example of somebody who has a healthy relationship with their feeding tube as well. And that's what I love about it. He's got a great sense of humor, and he loves to hike. And so his joke is that, you don't want to hike behind him on the trails. So that's his little warning there. So lastly, what I want to do is let you know, so Maisie talked about it briefly in her presentation. I think Lisa mentioned it as well, but and I wanted to make sure you guys had awareness of this, is the little feeding tube information card. It's two-sided, and I've got a stack of them on the table right up front over there. There's 3 little stacks of them, but basically if you have a feeding tube, you can get your information on here. You can identify what sort of a feeding tube you have. If you don't know, you can go to your clinician and have them help you fill it out. But this could be something that would be really useful if you had to get admitted to the emergency room, or you had to have a tube replacement, just so you know, and they know where it was placed, what it's made out of, what access device is it, right? Because it may look like a gastric tube, but it might be placed jejunally, right? So these are types of things that you might want to identify on your feeding tube information card. So there's a stack of them over there, and I think they're available digitally as well on the Oley website. And I don't think we have too much time here. I have 5 minutes, I think, for Q&A. I'm actually really impressed with myself. My daughter didn't stand up. She didn't give me any evil eyes. So I have 5 minutes until Lisa begins her presentation, if there's any questions.
So my question is, when it comes to a button, and if you get a button that says it's, oh, hey, hi. So I'll start over. My question is that when you get a button feeding tube, and it says 18 French, is that the same size as the hole in the top of the feeding tube where the connector goes in? Like, is the bottom part of the feeding tube that's internal, that French, the same as the hole that is sticking out of the body?
Yeah, I think there's differences depending on the French size. So I don't, off the top of my head, I don't know the exact, you're talking about the end fit opening?
It doesn't matter whether it's end fit or not, because it's like
just the button through the valve.
the button itself. So
right.
Like, if you're choosing a formula and say you need that formula to go to a specific French size, do you have to take into account the actual feeding tube, the top, where that connector would go, like for a button?
Yeah, so your commercially prepared formulas, I think the only exception would be with blenderized formulas, might have issues with that, but the standard commercially prepared formulas that do not have whole blended food in them go through, so you don't have to be concerned about what size French your tube is or what size the opening of the button, and even the connector to the extension set. So like a right angle extension set has a turn as well. But I don't know the exact sizes of those off the top of my head, unfortunately. But it's not something that you have to calculate your tube and then figure out which formula fits through there. If it's a commercially prepared formula, it will go through.
Got it.
Yeah.
Because that hole is smaller than, no matter what size French it is. That's kind of the general question, not the actual size, but is that hole smaller than the actual French of the tube?
I don't know the answer to that, off the top of my head. It's a really good question.
Thank you.
Stumped.
I have another quick question. What percentage of people actually get infections from these feeding tubes?
Yeah, so the literature has a varied reporting. It's like, I think the literature says a range between 3 and 18% of patients. My personal experience, my personal opinion, this is Cynthia Reddick's opinion, is that incidence is probably higher than that 3 to 18%, just from my observations at some point in some time. And when I say infection, I don't mean just bacterial. I think bacterial infections are the least common. I think yeast infections are more prevalent, but I don't have research that backs that up, because when the research refers to infections as a whole category, as opposed to discerning between the two. Mm-hmm.
So the question is, as a clinical provider, if a patient dislodges their tube and they present to the ED, is there a general census on, is it a time frame or just a clinical comfort level on if it's an ED provider or if we have to call in gastro and they have to take them to endo to replace the tube?
So emergency will try to put the tube in, and they're going to put in whatever they have there. So if a patient brings in a tube, they may or may not use that tube. They'll use what they have. And they'll assess the stoma site for any swelling or obstruction. But if they can feed the tube in, then they'll do that. And then they'll verify that it's gone all the way through, either through x-ray or through auscultation or a flush of water. But if they're not able to get it through in just what we would call bedside, then they would go into procedure to have that done. Mm-hmm. And there's probably people in this room that have experienced that. I think we're at time. She just flashed me my time card. Thank you, everybody. Are you going to use the pointer at all? No? Are you a pointer user?
No.
Okay, I'll take the extra one away then, so it doesn't confuse you.
Great job.
Thank you.
That was very informative. I learned stuff. How are you?
I'm great.
Are you good? Okay. Do you want me to introduce you real quick?
Sure.
Okay. Sure.
Sure.
All right. Thank you so much, Cynthia. Next, I would like to introduce Lisa Epp to discuss Aspen's recommendations for blenderized tube feeding. So this is the second EN session, so feel free to stay. And I'd like to welcome Lisa Epp.
What do you put? Okay, I do not do well standing in place, so I will tether myself to this podium. You can see my financial disclosures here, but another disclosure is I'm talking about blenderized tube feeding today as an option. I'm really not going into why would you do blenderized tube feeding, what are the pros, what are the cons. This is more just to say you've maybe already considered this as an option for yourself and how would I do this. My objectives here. So one slide, just to kind of give an overview, the pictures that we have here, we actually sent cameras home with our patients and said, take pictures and show us what this looks like in your home. But I've listed here along with some references just as why some of my patients or why consumers might say that they want to do blenderized tube feeding. So improved bowel regularity, help with the good bacteria in our gut, improved satisfaction has been noted, decreased vomiting or decreased retching and gagging, potentially cost saving, accommodate food allergies or food intolerances just because you want to, and potentially improve tolerance. So I have the references here as well as the end of my slides, but I don't really want to go into the details of that because the purpose of the talk is kind of, I've decided I want to do this, what should I consider next? So the first thing is discuss it with your healthcare team. Now, how I became kind of interested in blenderized tube feeding, I had been working at Mayo for maybe 4 years. And of course, I felt like, oh, I've arrived. I'm in this practice of seeing patients at home on tube feeding, and I feel like I know what I'm doing. And I was talking with a patient, and he's like, super stable. I was like, is there anything I could do to make your life on tube feeding better? And he said, well, I'm going to be honest with you. If you could get me a bigger French size tube, that would be great because the blended sardines that I make just keep clogging up this tube. And I'm like, what? Blended sardines? He's like, well, now that I know you, I can just tell you, I don't use what you have prescribed for me for the last 4 years. I donate that somewhere and I blend up my own food. And I thought, okay, I got to learn about this because people are feeling like they're needing to hide this from me. And that's exactly what I know some of you might be feeling like. But with these new Aspen guidelines and resources out there for clinicians, I feel like it's going to help really take away that fear that a lot of clinicians have. So that's why I say discuss with your healthcare team. Don't feel like you need to be secretive. Make sure you have resources available, like time for yourself and time with a clinician that can help you, and the equipment that you need, which I'll talk about. And then really think about, what do I want this to include? Are there allergens that I want to remove? Are there certain foods I don't want to have? And am I using it to manage something like reflux? We might want that to be a little bit thicker, or for constipation, making sure that we have enough fluid and enough fiber. So there's really two options. And at first, we did not have prepared blenderized tube feeding. I'm going to tell you that's what Aspen has decided to call home blenderized feeding, is prepared blenderized feeding. So that's all we had at first. And then we have now a lot of commercial products. So when you compare the two, the differences are going to be cost, but really that's based on your individual insurance, because I have many people say it's actually cheaper for me just to blend family meals because the formula my child was on is really expensive and our insurance doesn't pay for that. On the flip side, if your insurance is paying 100% for your formula and you're going to start blending foods that are expensive, like organic kale and blueberries, that might be an increased cost. So I don't really think we can make a blanket statement that one is more or less costly. Same in terms of time and energy. You know, you might think that preparing your own blenderized feeding is going to be more costly, time-wise, but if it saves you time in laundry from vomiting and time from worrying about your loved one tolerating feeds and things like that, it might be actually a time saver and an energy saver. Lastly, I think this is kind of where a lot of clinicians have worried in the past, is about microbial contamination of making your own formula. So obviously, if you have a commercial product, in theory, that would be less likely to have contamination. However, these can really be mitigated with good food safety practices. So you might be wondering, kind of the question that we had before about French size, how do I mitigate clogging my tube? Because people really worry, I'm going to have this thick formula and it could clog my tube. So this group of about 10 content experts got together with Aspen and did a literature review and really tried to answer these questions. And the way that we felt was the most evidence-based, but also somewhat easy to do at home, would be to measure the blenderized feeds using the International Dysphagia Diet Standardization, which might be a very foreign concept to you, but really what it means is a measurement of how viscous or how thick a blended formula is. So you can see with liquids, like on the bottom, we have thin liquids, then slightly thick, mildly thick, moderately thick, and extremely thick. So I'm going to use that kind of as a comparison. And you can measure that at home. So as you're starting to build your own recipes, it's a great safety net to say, okay, mildly thick formula will work this way. Moderately thick formula will work this way. So this concept here I'm going to use throughout some of the recommendations. So you can see that you would put the blend in a syringe and follow this process, and it would tell you essentially how thick your blend is. So you can see at the top, extremely thick is the most thick, to thin liquids. So what do I need? Normally, a gastrostomy tube would be preferred. However, nasal tubes, the group felt like, could be used on a case-by-case basis, as well as jejunal tubes could be used on a case-by-case basis. We're really unable to make specific recommendations about jejunostomy tubes just because the hang time of a home-prepared feeding is 2 hours. However, many of the commercial products have 8, 10, or 12-hour hang times, which likely can be used with jejunal tubes very safely. Both legacy and small bore connector tubes have been studied with blenderized feeding, and both of them work. A 14 French or greater tube is preferred, but I will say this is really based on expert consensus. If you look at the papers that are published, all of them go back to really a paper that was someone's opinion. And actually down to 10 French tubes have been studied to be able to be used for blenderized feeding with thinner blends. But the group felt like if we say 14 French, that's kind of a safety net. There's really no evidence that your tube will wear out more quickly or need to be replaced more quickly, and no evidence that they clog more quickly. Again, we looked at all the evidence out there, and some of them looked at clogging, and there wasn't a difference between commercial products and blenderized products, even though I know we think that should be a greater risk. As long as we're flushing properly with water before and after the feed, really that risk can be mitigated. So you might be asking yourself, what blender would you use? Now, if let's say you have your jaw wired shut and you're gonna be on enteral feeding for 3 months, you might choose not to invest in a $700 blender, right? So the duration of therapy should be taken into account, but there's really great options with professional grade blenders, a jug blender like that you can get at Walmart or Target, or a wand blender like an immersion blender. Our group did study blenders, and the blenders that were on the market at the time, the Vitamix is kind of touted as the gold standard. It does produce much smaller particle sizes than other blenders, and the smaller the particle size, the less chance of it clogging the tube. However, increasing blending time of kind of a less expensive blender to 3 to 6 minutes really actually does produce small particle sizes like the Vitamix. But if you can imagine turning on a blender for 3 or 6 minutes, it's a really long time, and it will blow out the motor more quickly. So if you're going to be doing that frequently, then it might make more sense to invest in a Vitamix. So one of the questions we asked is, can you make a big batch of blenderized feeding and then freeze it for later use? And the big distinction I want to make here is when you make your own blenderized feeding, that follows the USDA guidelines for food. It's not a formula. We're not considering the Aspen guidelines for formula. It's really the food safety guidelines. So absolutely, you can freeze a big batch and thaw it and use it later. We want it only in the, or take it out of the refrigerator that you're gonna use it within a day. We want you to thaw it safely, just like you would any food, but likely it will have to be reblended when you take it out of the freezer. Hang time, this is the number one takeaway I want you to leave with, and that is that if you prepare your own blenderized feeding or you add a food ingredient to any commercial product, it decreases the hang time to 2 hours. I wish there was evidence that would show us that using ice packs or other methods would mitigate this, and I'm hoping that in the future we will have that research, but right now we just don't have any research to show that there is anything we can do to decrease or increase the hang time of a prepared product. We want you to store it in the refrigerator and throw it away after 3 to 4 days, just like we do leftovers. Unlike the commercial products, which we're following the Aspen guidelines for, you want to discard that after it has been refrigerated for 24 hours. So cleaning of the blenders is actually one of the things that really mitigates the bacterial contamination of making your own blenderized feeding. Most blenders have their own manufacturer guidelines as to how they recommend cleaning them, but actually the FDA has a really nice process, and it's what some of the studies have used to have people do home blending at home and really decrease the bacterial load of those blends. So taking the blender apart, soaking it in a bleach water bath, letting it air dry, those types of things can really decrease the risk of bacteria growing. The administration sets, however, like a gravity bag or like a pump bag, we really don't have great guidance on how we're supposed to be cleaning these products. And so right now, with the evidence we have before us, the recommendation is to rinse the bag with safe drinking water between use to clear any debris. If it's in the hospital, it's likely going to be thrown away after one feeding. At home, the recommendation is then that bag be stored in the refrigerator in between uses and discarded per manufacturer guidelines, which is 24 hours. So rinse it out after breakfast, put it in the fridge. Rinse it out after lunch, put it in the fridge, throw it away after dinner. Now, our group did kind of put forward a question, and that is that other feeding supplies can be cleaned using these CDC guidelines for like bottles and syringes and medication adapters and things like that. And the question is, should feeding sets be put into that? And so we hope somebody will provide further evidence for us, because it would really help mitigate the bacteria that could grow in a bag if we were able to clean it with this water bleach solution that other feeding supplies can be cleaned with. But right now, we don't have that evidence. So some recipes. You might be thinking, well, I am interested in doing this, but how in the world do I get started? And so looking at websites from a federal agency, a large professional organization such as Oley or Aspen, to really look at what resources there are there, which there are a lot. The three options that I've given you here are things that I feel like are easy for you to do at home. And I just want to point out, you're going to see some pictures and syringes of blends. So this is from a patient of mine who's very into, so she uses the 500 calorie base recipe that I'm going to show you. And she is really into colors. So for all different holidays, for Halloween, it's all orange and black and red, white, and blue for 4th of July and things like that. So you're going to see some of her colors here, which are amazing. And all of them are based on this 500 calorie recipe, just swapping out some of the foods. So the first one I'll mention is the Complete website. So anyone has access to making a profile on the Complete website, and you can kind of put in a calorie level, your goal volume, any allergies that you have, and you really build recipes using categories. So it first gives you a list of, here's a nutrient-rich base. So that might be a plant-based milk, that might be a dairy milk, that might be a commercial product. Also, other categories like fruits and vegetables that are high in vitamin A or high in vitamin C, or calcium-rich foods, protein-rich foods. So it kind of gives you a food list to choose from. And then it builds a recipe for you, creates a shopping list of the foods that you need to purchase to create that recipe, and allows you to print a PDF of that recipe, so you could take it into your healthcare provider and kind of say, this is one of the recipes I'm thinking about using. Would you be able to take a quick look at it? Providers can also use it to help you build recipes as consumers, and it's a great way to kind of take ownership, I guess, of your own recipes. So these, like I mentioned, are the categories that you choose from. So the nutrient-rich base, the protein foods, fruits and vegetables, potassium foods, grains, and healthy fats. Did not mean, back. Okay, so what are some features of this? It allows you to make a seven-day meal plan. You can customize the recipes for exactly what you want. It calculates the volume, which is great, because if you have volume intolerance, if you say, okay, I can only have 750 meals a day, or I can only have 1,000 meals a day, it helps choose food that are more nutrient dense. For example, a piece of bread is probably going to add more volume as a carbohydrate than, for example, grape nuts, which grind up and don't add a lot of volume. So it helps pick foods that are in the categories that don't add as much volume, helps you with your shopping list, and like I said, it gives you a PDF that you can take to your healthcare provider. So I'm going to tell you, this is the way that I am most comfortable doing home blends, and this is how. So we have about 2,000 patients that are on tube feeding at home that our Mayo Clinic team follows. And our research shows that at least 55% of them do some blending in some capacity, whether it's one meal a day, one meal a week, or just a birthday meal or something like that. So it is a large percent, and therefore this is the recipe that we have created. It can be modified to, make a 1,500 calorie recipe or things like that, but it's a good start. And each of the foods we have actually tested. I think 2011 is when we actually tested these recipes. So honestly, it makes me a little bit frustrated that we're in 2023 and finally these Aspen guidelines are going to be published. But nevertheless, we are there. So this is a recipe that we do use a lot, and we have tested each of the foods on this list. Now, I normally tell people, once you're comfortable with like oatmeal, yogurt, milk, banana, green beans, and chicken, once you get that blend down and you're like, oh yeah, I know exactly how long to blend it, I know the consistency, I don't have any chunks, then it's perfectly fine to open up other foods. Like, okay, let's change out the banana for blueberries. Let's change out the mandarin oranges for something else. But it's just hard to test every single food combination. So it's a good way to start. And like I said, it's what most of our patients use. So this is actually an example of what those 500 calorie recipes look like. So each of those jars are a meal based on the 500 calorie recipe. And then that is the varying volumes that those meals produce. Like I said, this mom is amazing at making colorful blends and really wanting things to look pretty. So she knows which foods to choose in each category to make these colors. But you can see the amounts are a little bit different and each blend looks different, just like our meals that we would choose to eat orally. Another way that you can make recipes is using My Plate on the myplate.org website. So there's really two ways that you can do it. You can make recipes for ages 1 through 8, and those are based on average weight and height of a child at that age. And then there's a category where you can make recipes for 9 and older that actually do allow you to put in height, weight, and physical activity to help you develop a calorie level that you're trying to make the recipes at. So this is what it would look like for a 14-year-old, for example. So it would tell you, okay, I put in height, weight, activity level, and it told me that I needed 2,800 calories. And then it tells me from each category of food, how would I make a blend that would meet all my carbohydrate, protein, and fat needs, but also micronutrient needs without needing to add supplements. So some of the questions that we get about any of these three options, and you can see this picture here. This is actually from a while ago, but I always think like, I wonder if my kids know what I do. And I walked into my daughter, at the time she was 7, playing dolls, and I walked into her room and this is what she was playing. And I said, what is this? And she's like, well, my doll needed a feeding tube. So I put her backpack on her wheelchair and she's just fine. So I was very impressed that she came up with that on her own. So for questions people ask, do I need a multivitamin? In the guidelines, we have basically said the general answer is no. So you should be able to get all of your micronutrient, all your vitamin, all your mineral needs with blending foods. But that being said, if you have volume restrictions or food restrictions, you may need a multivitamin. That's where the Complete website can be helpful, because it actually tells you if once you make your recipe, if you're low in sodium or low in calcium or low in iron, it would tell you how much you might need to supplement. But in general, you should not need to take a general multivitamin. Same thing with salt. I will say that when people start blending their own food, they get really excited about kale and blueberries and sweet potatoes and all these healthy foods that we want to get into our bodies. And they forget that we still need ranch dressing, because ranch dressing is giving us sodium, potassium, and some other micronutrients that we don't really think about. And not that you need ranch dressing, but it is a really good way to say, like, okay, if you're doing broccoli and carrots, just do a squeeze of ranch dressing in there, just like you would if you were eating them by mouth. And that can really help get those minerals that we might not be getting if we just use all foods that are not processed at all. How much water do I need? Well, our water needs really don't change based on if we use a liquid commercial product, a commercial product that's blended, or if we blend our own food. In general, we feel like when you make your own blenderized formula, it's about 70% fluid. So if you would calculate, okay, I made 1,000 milliliters of blended food, 700 milliliters of that can be counted toward my fluid goal, and then add fleshes on top of that. A lot of people that do make their own blends choose to give water or fluid outside of the blend, because it can just add a lot of volume. So when you think of water, water doesn't have to be digested, it's just absorbed. So I give water fleshes, it probably leaves my stomach within 5 to 10 minutes. If I put more water into my blend, now I've made this bigger volume of diluted formula that has to be all digested and absorbed, and might just lead to some volume intolerance. And so normally, in general, we like to give the water or other fluid fleshes like Gatorade, Powerade, Pedialyte, almond milk. Anything can be used as fluid fleshes outside of the blend. But 70% water is kind of what we're estimating that most home blends are. Can I use the same blend every day? Absolutely. You can use the same blend every meal, every day. You can change it up every meal, every day. There's really no right way of doing it, as long as we know that the blend that you're using every single day gives you all of the nutrients that you need, with or without supplementation that you might be making. So like I said, aren't these colors just insane that she can do? It's really... And then she puts placemats out. You can't see it very well, but this was for Christmas. Actually, she had this placemat out with red and green and white on it. So really making that mealtime a lot more fun for her child than I think I would be able to do, for sure. So just some tips from consumers, but also from people in the group. So we had people from the US and Canada that have a big portion of their practice using blenderized feedings at home. And one of the recommendations that was given was using a coffee grinder to grind up vitamins, nuts, or seeds before putting them into a blend, because it can kind of pulverize them into a powder so it blends easier. Keep the skin on the fruit for added fiber. Warm blends definitely push easier with a syringe. They flow easier in a large bore gravity bag. They flow easier in a reusable feeding pouch. Cold blends usually don't feel quite as good going in, but are definitely take more force to push and a little bit harder to get through the tube. And then another good tip, and this was a tip I got from the group because I hadn't thought of this before, but as we're cooking vegetables, using that water as what we use for water fleshes or for the fluid in the blend to help thin it down, just so we're not losing those nutrients that are coming out in the water from boiling, like potatoes, or even if it was oatmeal or rice or something like that that still had some liquid left, using those. So how can I save money? Some people are worried that, okay, if I do this, it's going to increase my grocery bill. So buying foods in bulk can really help, especially if you're batch cooking a 14-day supply at one time. Having pinto beans that you buy in a bag that you cook are a lot less expensive than buying canned pinto beans, for example. Using Frozen, canned, or jarred vegetables is perfectly acceptable and a way to save money. And then you can buy online refillable food pouches. There's many different brands of them. Some of them are available through your home medical equipment company as well, but these can be washed and reused. And so if you were needing to purchase them out of pocket, sometimes it can be less expensive than, for example, buying like breast milk freezer bags is kind of what people had told me they had used in the past, but those really can't be washed and reused. And so if you were using that to freeze blends, then that could get costly. So these pouches can help save money that way. How can you save time? Well, you can make a large batch of blenderized feeding at one time and freeze them to use at later times, as well as use things like an Instapot or a slow cooker or a crock pot to make proteins and grains and vegetables in large amounts, just like we do to save time when, I throw food in the crock pot. And when I leave in the morning and it's done at the end of the day, you throw food in the crock pot in the morning, and then at the end of the day, you can maybe do a batch blending with some of the foods that you have prepared in the crock pot. And then get creative. So I've had people say they use muffin tins, ice cube trays, also just freezer bags flattened in the refrigerator. A tip one mom gave is that putting a piece of parchment paper in between the freezer bags can help so they don't stick to each other, because when you put that warm blended food in the freezer and then it freezes, all the bags want to stick together. And so she showed how she put a piece of parchment paper in between, and that really allowed her to stack things in her freezer rather than having kind of bulky bags of like frozen muffin size or ice cube size things. But different things work for different people, definitely. So I know I ran through that kind of quickly, but I do want more time for questions because I know the specifics of starting doing home blending or prepared blenderized feeding may be daunting, but I do feel like it is kind of the wave of the future as an option for people who are on enteral nutrition long term, especially now that we have, many people just like on parenteral living decades that may want different options. And if you want to stay on commercial product for the rest of your life, that is totally fine too. I don't want to discourage that, but I'll open it up for questions if people have specific questions about blending. And I think we have microphones over here, which might be helpful. That way the people that are listening to the live stream can hear the question and the answer.
So my question is about, I have one serious and one silly question.
Okay.
The serious question is, has there been any conversation about using like a commercial USD approved sanitizer like Star San instead of bleach to decrease that risk of like improper rinsing and then you accidentally feed a small amount of bleach versus like Star San where it's technically safe to consume?
No, but can you write that down, that name of that product down for me? Because no one in the 2 years that we met ever brought up that product. So yes, I would love to look at that.
And then the silly question is, Miss Maisie here is my lovely girlfriend, and she's made the joke that in PN nutrition, it's frowned upon to do PN slushies. Mm-hmm. Is the same true for enteral slushies?
Really good question. So before like 1970, our option was EN slushies. There weren't commercial products, and it wasn't frowned upon then. Some people in this room may have learned that in their internship or in their training to become a dietitian, because in the 70s and 80s, that's what we had. Once commercial products came on the market, it became very taboo to do your own blending. And that's where people went into hiding, basically, and said, I don't want to tell my doctor I'm doing this because I don't want to get in trouble. Over the last 10 years, we've seen a shift into, especially just as we learn more about our food supply and foods that are good for our bodies and maybe foods that we want to limit in our bodies, it's becoming more accepted for sure, but I don't feel like we're at the place that we want to be at, and I do feel like these clinical recommendations, which is 69 pages long, coming out from Aspen is going to be a huge step in the right direction because it's a large national organization that's saying this is safe and fine to do, and hopefully that will take the taboo away from the slushiness. Anybody else? Go back here first and then here.
Hi. A question my husband and I had, and one reason why we aren't blending our own food is because it has to be a certain consistency to get through the tube.
Mm-hmm.
And once you run your food through the blender, then you have to loosen it up a little bit, either with water or tea or juice. And so our concern was, is he getting the right amount of nutrition after we thin out the food?
Mm-hmm. And I think that's a fear that a lot of people have because you can't look at that label and say, oh, this is exactly what I'm getting for sure. I think you would be very surprised at how little or how thick of a formula would actually use. So applesauce consistency is the easiest way to describe what a lot of my patients use. So you might be feeling like I need to get like a thin smoothie type of consistency, and that's what feels like we have to add a lot of fluid to. But really in theory, you shouldn't have to be adding extra fluid. You should be able to blend food in a blender and be able to get it to about applesauce consistency and give it without adding a lot of fluid.
Okay, thank you.
Does the paper address the impact of using home blends to insurance reimbursement for the supplies? Or also does it also address how can we advocate for insurance coverage for the commercial blended formulas?
Yes, it does address that. And obviously the cost of or the reimbursement is different based on what insurance you have. But for example, if you have Medicare and you're home blending and you're not ordering a commercial formula, you lose your reimbursement for the supplies that you need. So if it's extension sets or syringes or anything that you're using, those things would end up being paid for out of pocket if you're Medicare. For example, in Minnesota, we have 100% coverage for all commercial blenderized products. And that was an advocacy effort. I know not every state is that way, but that is part of what is on Oley's advocacy agenda is kind of nutrition support is a right for all people, and all people should be able to choose if there's a product that they would prefer to put in their body versus another one. So it's in the paper and on the advocacy agenda.
My question was similar to the one that was asked earlier. And when you say applesauce consistency, and you showed the ITSE chart earlier, what ITSE level does that meet? And is there a level that you would say it's a no-go and you have to stop there?
Yeah, so I'm gonna go back to that really quickly. It really depends on the administration method. So for example, if you syringe your food, and I mean push it, not gravity syringe. Let me get back to here. And the paper addresses this. Oh my goodness, sorry. It doesn't want to go as fast as I'm pushing the button. Okay, so all of these liquids will work. So extremely thick liquid will work with a syringe. Moderately thick liquid will likely work with a large bore gravity bag, and slightly thick liquids will work with a pump. So if you saw on this slide, it goes into food consistencies, which you might be used to, like mechanical soft, pureed, things like that. Those will probably not work at all. But anything extremely thick to slightly thick will go through a 14 French or greater tube. It just depends on how much force is needed to get that liquid in. And that's why, like, if you have an extremely thick liquid, you would need to push it in with the syringe, versus a moderately thick would flow in a large bore gravity bag, or a mildly thick would be able to be pumped through a pump.
Thank you.
Yeah.
Are you guys addressing at all the problem I'm running into with nurses at school refusing to push a syringe? Nowhere in California will they push a syringe. They want it to gravity flow, so we cannot get anyone to push a syringe.
So this isn't in the paper right now because, as you can imagine, after 69 pages, Aspen's like, no more. Any other information will have to be in. We're going to do kind of like some leaflets after the fact of one, and one of them is going to be for, we're going to call it hospital use, but it's kind of making me think that we should call it something different. And what we know is that most kids swallow is about 5 milliliters and most adults swallow is 15 milliliters. So part of what the next round of information is being able to say, if we push 5 minutes, that would be, or 5 mils, like for a child at school, it can help us break down a 60 mil syringe on what would be physiologically appropriate. That might be something. Again, we're spoiled in Minnesota. Our school nurses do feedings of all kind, as long as there's a letter from a healthcare provider that says how to do it. And most of them, when we do syringe push, we say one syringe should take 1 minute. And then they can kind of time it out that way. But I do feel like this leaflet that's going to come out, and if anybody has any recommendations of what to call other than hospital, because you can think of like group homes, assisted living, even day programs that some kids and adults go to have similar kind of worries. And so that's really what we want this to be for. I don't know a word to call it other than hospital, but you'll have to wait a little longer for that, sorry.
What's the planned release for the guidelines to come out?
So they were approved so they went through the peer review process over the last 6 months. They were then once that is approved, they have to be approved by the Aspen Board of Directors, and they were approved at their June meeting. So now it's really just the legal wording that needs to go on the paper and publication in NCP, which should be in the next couple of weeks, I would say. Mm-hmm.
Hi, Lisa, great talk. I just have one comment. I work in home care, and when you mention large bore gravity bags, I just want to make sure that everybody understand there's 2 types of gravity bags out there. There is a standard gravity bag and has very skinny little tubing, and then there's that large bore gravity bag. So if you are not getting a large bore gravity bag, just talk to your home care company and they can help you with that.
Thank you for clarifying that. Anybody else? If you're interested in doing home blending, but you're nervous, a great way to start, and I had a patient this last week. He's 80, he'd been on enteral feeding for 10 years, but he's like, I just want some of my favorite foods back. So what we did is we said, okay, 2 cartons of your standard formula are giving you 700-ish calories a day. Let's do 1.5 cartons of that plus 185 calories of a food that you want to get back into your diet. Like sweet potatoes was one thing he really wanted. So we did 1.5 cartons of his standard formula plus 1/2 cup of sweet potatoes with a pat of butter. And that really makes a pretty thin consistency. We did 5 recipes like that. And he's like, let me do this for like 2 months and then I'll get back to you. 3 days later, he called and he's like, okay, I'm ready to do everything myself. I'm ready to transition. So I think it's a good way to just dabble to get your confidence up, that you're not going to be clogging your tube, that you're not going to be creating this volume that's unmanageable. And you're going to still have that kind of base of your commercial product that will give you the peace of mind. So that's how I would start. All right, well, if there's no more questions, we'll break. I know, I have pants on.
Thank you all so much. Just another reminder, before you make any changes to your medical care, make sure to chat with your provider. This is just an option. Find whatever works best for you. Lunch will be served in Regency DEF, where the exhibit hall is. The next sessions will start in ABC at 2:45. If you dropped off your kids at Kids Club, please go get them. Thank you.